we're using these in second or third line therapy right now. I know some of these studies are being looked at with the lisocabtagene in early lines, but we have some randomized phase 3 trials coming up.
Yeah, so the ZUMA-7 trial, which is looking at exicabtagene ciloleucel against standard of care in the second line for patients who have either primary refractory disease to an R-CHOP-like regimen or who relapse within a year, which we know is a very high-risk group of patients that have a diminished long-term survival after autologous stem cell transplant. That's been fully accrued, so we're eagerly awaiting the results, but I think alluding to the discussion we had earlier about treating patients with decreased tumor volume and also treating patients in earlier lines of therapy may lead to improved outcomes as well as improved T-cell fitness. And so, the bar that these trials have to beat is, essentially a long-term PFS of about 30% for this high-risk group of patients. And we're already seeing that in the multiply refractory setting. So, I don't have a crystal ball, but I'm optimistic that this is going to beat auto transplant in that setting.
I think we're all optimistic that that's going to happen, and we're eagerly anticipating the results of ZUMA-7. The difference in the ZUMA-7 trial versus the other trials, the Belinda trial or the Transform trial, that ZUMA-7 does not allow for any bridging therapy for patients who are randomized to the CAR T-cell side. Again, we talked before about it's a relatively short manufacturing time, so that's not likely a huge issue, but that's one difference that will come out from this versus the other second-line studies where Belinda and the Transform trial allow for randomized CAR T-cell patients to get bridging therapy, as well as potentially to cross over if they have standard of care chemotherapy and don't respond.
Yeah, I think the other issue is that when we're comparing against transplant, you have to remember a lot of people don't make it to transplant, so they fail before they even get there because they don't have enough responsive disease to get to transplant, which automatically then makes them a candidate for going, for standard of care, which we have the 2 approved agents. Also point out that the lisocabtagene maraleucel is being explored in transplant in second line for transplant ineligible patients, so patients who can't get a transplant. Although that,
what does that mean?
I know that's a tricky thing to decide what that means. But do you think are we gonna make auto transplant a historical procedure at this point for lymphoma?
I think we need to see what these randomized trials show, but I would caution, let's play it out. What if the randomized trials show that CAR T is better in the second line setting? When patients relapse after CAR T, which is bound to happen, even if they have higher durable response rates in the second line than in the refractory setting, we don't know how to treat those patients. Should they be cross back over to get auto transplant, and some centers are doing that in patients who are enrolled on this trial, and others are using different approaches, allogeneic transplant or others.
Yes, and I also would like to point out that the ZUMA-7 trial really only was choosing patients who actually relapsed within 1 year. So auto is really, for me, still a very valuable approach for late relapses where we know that historically we can cure 50-60% of those patients. So it's not just going to disappear, but we just have to look at the data very carefully, and it really depends on also if we just 30% or it's 50 or even 70% of the crystal ball. Yeah, exactly. We don't have that data yet.
I would say, though, that we're already, at least at our center, seeing a decreased number of auto transplants being performed. And with the approved CAR T-cell therapies, we know that a patient with a partial response going into an auto transplant has a worse outcome than a patient with a complete response going into auto transplant. And some physicians are not enthusiastic about taking the patient to auto transplant with a partial response, knowing that CAR T-cell therapy is there. So,
well, that is a problem with these trials, right? Because the trials have pretty much insisted that if you have a PR, then you're still a transplant candidate. Whereas many of the transplant centers, if you're PET positive going into an auto, we don't want to treat those patients. So, I think that's unfortunate. Most of the trials started off the other way, but FDA essentially forced the trial design. All right, I want to just move on just for the last couple seconds in this section. There are other lymphoma histologies, right? It's not just diffuse large B-cell lymphoma or aggressive lymphomas. There's exciting results in mantle cell and follicular lymphoma. What do people think about those results?
Well, I think the mantle cell lymphoma, which is going to be presented today, I think that data is very exciting. They're looking into patients who are ibrutinib failures, where we historically know those patients are doomed. usually just 4 or 6 months. That's most what we can get out of those patients. And based on the abstract that I read, being as an investigator in that clinical trial, it is really breakthrough therapy designation, what we see here in these patients.
Yeah, I think we're really excited about that, and as well the ZUMA-5 trial that's looking at follicular lymphoma?
So the ZUMA-5 trial, the follicular lymphoma arm is fully accrued, and so we are, awaiting whatever the FDA prescribed as the amount of follow-up the trial needs to have in order to see the results. But we know from work done at the Hutch, and we know from work done at UPenn that in follicular lymphoma, the response rates are even better than what we see in the complete response rates are even better than what we see in diffuse large B-cell lymphoma, that at least with 2-year follow-up, there are very few relapses, or almost none, I think. But of course, with follicular lymphoma, 2-year data is not going to be enough to be practice-changing, I don't think, because this is a disease that has a very long natural history and that oftentimes takes quite a long time to relapse. And so I think we're going to need to see more mature data for that. But I think it's a really exciting time for treating some of the indolent lymphomas.
So I think what we're seeing is that when these new therapies get approved, they get approved in the relapse refractory setting, and then they're quickly going to start moving up. And I think the ZUMA-12 study is even looking now at frontline after 2 cycles of therapy with PET-positive residual disease going directly to axicaptogene. So these are really exciting studies that's going to change the therapy for lymphoma for many years to come. Thank you very much for your participation.